Hey, it's Alge from Subluxations Anatomy. This is the third video in our series on the atlantoaxial joint, and we've been talking essentially about how the subluxation, what is understood as a partial dislocation, is first and foremost just a not adequate explanation of how a joint might get stuck. And not there's anything wrong with the tissue per se, it's just that because it's entered common terminology, it's no longer serving the purpose it once did. And so we need to have a better understanding, because just to name it bone on bone actually does not make a lot of sense. So we established that in the first video. In the second video, we talked about how different orientations of tissue, whether that's muscle or whether it's tendon, ligament, fascia in general, they can pull on that AA joint simply based on attachment, or they can put it in such a position that it is in a different place. It can, rotate the head, for instance, and that will occur at that AA joint. This is a superior view, for instance. And when that happens, because it usually pulls in multiple planes, so it might pull to one side, but it also pulls down, we can get pressurization of that joint. A compression, not in the medical sense, but enough pressurization of that joint to basically stop it from moving, keep it outside of a normal position, and then decrease its general range of motion because of paired motions in the human body. And subluxation is a fine way of explaining that, but again, it just doesn't quite do it. So we're almost steering away from that. We're talking about the AA joint as it comes into different positions based on fascial pull and what prevents it from reducing. And so this, because it's a fascial structure, a fascial based understanding of this joint, we also have to say that it may be active contraction through muscles, pulling quite hard, but as well, it can be tendencies over time, whether that's a fibrosis, whether it thickens and is no longer capable of being long again, returning to normal length, or it could be by habit, wherein we actually change the shape of the articulation, how that AA joint might adapt over time based on usage over a long period of time. So if that's the case, then we could start to see how this joint would be then incapable of moving as it once did. So that's what we're going to talk about. That's where we finished off last time. What we're going to talk about is now the anterior relations of that. We've got a few things. Now, this particular portion of the video series is actually really an excuse to talk about a very interesting thing that's been starting to come up. And it's by no means completely proven. We're just getting an understanding. But it's been noticed that as the neck, the cervical spine, changes in position and perhaps changes in tensions throughout its articulation, it can be related to, and we don't know exactly how it's caused, but it's related to sensations from the viscera, nausea, vomiting, that kind of thing. And simply because the AA is in the region, so the AA would be right about here if the mouth was open. We want to make this relationship and show how it can be related to that. Now, the theory as to why we might be getting some kind of a visceral sensation from the turning of the neck or the extreme position neck is not too difficult. Why it might be happening is not too difficult. Understand that there's some really important nerves that actually run through the neck. I'm going to steer clear of the phrenic, and that's the most painful thing that I can think of in the entire world. I'm going to talk about the vagus today. And the vagus actually runs through the neck, going along with the carotid artery. Put it there, and then the jugular vein there. It's tied up in a single bundle. Now, understand it's on both sides. And so that means it's either side of the neck. We could talk about either rotation, either direction. But it's coming from, this vagus nerve is actually coming from what's called the jugular foramen. So this would be the spinal cord right here. We're looking at the skull from the inferior side. That's where the spinal cord comes out. But there's a number of different openings through here, like these guys, all through here, that pass nerves and arteries and veins. And through the jugular foramen, which is right here, this actually passes the vagus nerve out, and it wants to meet up with, eventually, as it descends, the thyroid gland, for instance. It wants to meet up with the heart and lungs. But in a big way, it's actually going along with the esophagus, because it wants to get to and through the respiratory diaphragm, which is give or take right about there. And when it passes through that area, it's going to the stomach, it's going to the intestines, liver, spleen, pancreas, all the way down to about the large intestine, in fact, a good portion of it. So it's going to transmit. It's going both ways, of course. It's got a signal for motor, the descending portion, and it's got a signal or nerve portion for sensation. So it really is both directions. So this vagus nerve is really going through both directions. That means it can transmit what the nerve is telling something to do, but also what is the sensation of that nerve. And so if we were having nausea and vomiting, that's for instance, what's reported by the vagus. And the relationship between the neck position and, of course, the vagus is a pressure-based relationship. So, for instance, let's just take a little side here. For instance, if we have something that's called a thoracic outlet syndrome, where the brachial plexus that's coming roughly off the neck travels through and into the arm eventually at one point or another, do understand that this is a point of entrapment of a few different places. So it could be from the scalenes. There we go. Oh, that's not right. There we go. Scalene muscle. It could be from the pec minor muscle coming around like that. And it could be directly from this clavicle compression right here. So understand that in this disease, this condition, thoracic outlet syndrome, we can actually have a mechanical pressure changing the way a nerve works. It's also enough to compress the blood and the blood end, whether that's artery or vein. But it is a mechanical pressure that's creating a change in the afferent, the reporting signal, the sensation of a nerve. This is the same with piriformis syndrome, which I won't draw, but piriformis is the same. It's a muscle creating enough compression on the sciatic nerve to cause a change in sensation. So that's a big deal. So if you're willing to believe in that, it's not too unreasonable, though it's not fully proven yet, it's not too unreasonable that some of the stuff, I'll just say stuff, going on here could change the way the vagus nerve works and change the sensation of it. So this isn't unapproachable as a theory. Again, more time, more study has to be done, but it's a pretty reasonable thing. So I'm going to throw in a few muscles just to start to set a base. We're going to talk about the environment of this vagus nerve and why it could be related to visceral sensations. So the first one I want to mention is the longus colli, longus capitis. This is going right up all along through here. So I'm just going to, I'm going to leave it as just two fibers here. It is a vertically ascending muscle, and it goes right up, and it will attach into basically the occipital area, give or take right about there. If we're looking at this from a side view, this is the C2. The muscle runs up in this direction, and of course the atlas is right about here. So it runs right along that AH joint, and it's attaching at the front of every vertebrae. So that's forming kind of the back side of this thing. We've also got, and let me just throw that on a slightly different plane, we've also got the scalene muscles, and the scalene muscles are going to rib 1. There we go. I'll draw it on both sides. Rib 1 from the TVPs of the cervical spine. There's a few branches of those. There's a few strands of those, but largely they can be shown in that orientation. So we've got something that's very close to that vagus nerve, very close to what we call the carotid sheath. And I'm just going to do just a little bit of a cross section here. So let's say this is the vertebra here. That's a cervical spine vertebra. And if the carotid sheath with its vagus nerve is right about there, we can start to throw in some of the muscles. So that would be like the scalene muscle. This is a cross section. We'd be looking at that kind of a cross. And then, of course, we've got our longus colli, longus capitis, just for clarity's sake. Now, remember, too, that we've got some organs in here. I'm going to draw just the esophagus for this one. I'll throw in the trachea after, but the esophagus is actually all up in front. The vagus is coming down, and it's coming down to meet up with this esophagus, really, once it gets past the neck, it'll throw off some branches to the heart and lungs. But that esophagus is basically coming down, and it wants to aim for that respiratory diaphragm, so that vagus is kind of coming to the middle. So notice it's traveling towards the center. So if we threw that in, it would be right about there. The trachea is just in front of that. I'm going to erase this right after, but the trachea is just in front of that. So we're starting to occupy the space. We're starting to have less and less room, basically, because of all this. Understand that there's not a ton of room in the body. So to say that a nerve could be surrounded on all sides, really, really reasonable. Not a hard thing to understand. As we start to throw in some more muscles, you can kind of see how this can encroach upon an area. And normally, it's not going to cause much of any of a problem, but over time, well, certainly. So let's say we've got another big muscle, the sternocleidomastoid, coming from the mastoid process of the temporal area right into the sternum. Great name on that one. That's, again, wrapping over top of that. So if we drew it from here, again, it would be higher up attachment point, but it would be coming through and around like so. So that is a big deal, because again, it's actually wrapping right over that carotid sheath with the vagus, with the carotid, with the vena cava. So this is running over top. So if it contracts, if it changes in tension, that will be perceived, or at least put upon that carotid sheath and the vagus nerve with it. So we've got, quite a few options here. Now, let's say, for instance, and let me just make this cross-section as accurate as possible. So there's our carotid, there's our vena cava. We've got a few things. We've also got some of the hyoid muscles here too, and they attach exactly where you think. Thankfully, someone named these ones well. The hyoid bone is give or take right about there, and then we've got some hyoid muscles that actually go right into the sternum. So they are over top the trachea, and they can be palpable. They're palpable on the external surface. They would be right about there. So now, the space I've drawn, I've actually left some gaps in it, because it is difficult to draw this with 100% accuracy on the fly. But understand, there's a lot of stuff going on here. And these spaces, they really aren't there. They're there because of my own error. But just understand, think about it for a second. When we start to turn the head and neck, there's going to be a change in tension that it gets exerted, whether we turn it left or right, or we put in a side bend or something like that. There's going to be a change in tension in the area, and we are absolutely totally fine to do this, totally and completely fine to do this. And if we turn our head regularly, if we change the position of our head, especially with those twisting motions, we wind up the tension in the tissues as these all go longer. So if I was to turn the head, let's say, hard to the right through that AA joint, I lengthen this side. By comparison, I shorten this side. That's true in general. In general, I'm talking. So we take pressure off one side, we increase pressure on another side. So that's a big deal. If the nerve is reactive to that, the vagus nerve is reactive to that, we might be able to change the sensation of it. We might be able to create sensations where there normally shouldn't be. If, on the other hand, we add to that tissue over time through strain, thickening, and fibrosis, which is somewhat natural, scar tissue formation, basically. Not exactly scar tissue, but close enough. If we change it, we start to further encroach on that space, and we start to further press on that nerve, potentially. And so you can start to see how the mechanical might create the sensation in a nerve without there actually being any problem with the lower gut system. So this is it's an interesting idea anyways. With that though, there's got to be some kind of a compensator, and I love to find these things whenever possible. So taking away all this, going back to just the basic formation of this. If we have our vagus nerve, I'm going to draw on the other side now. Vagus nerve coming through here. I should probably get a layer. There we go. Coming through here and going down, going along with that esophagus. There is actually a muscle that does attach to that carotid sheath. Remember again, there's a carotid artery. There is a jugular vein. And it turns out, so this is all wrapped up in the same sheath. Leave that out. But there is a muscle called the omohyoid that actually attaches. It goes from the tip of the scapula, top superior portion of scapula, and goes over top, slight little attachment to that carotid sheath, and then will attach into the hyoid bone, which is, give or take right about here. There we go, attaching that hyoid bone. So this is a weird one. Why would this exist? It's a very strange formation. So it wraps around that carotid sheath, attaches into it, and it's got two separate bellies, two separate portions of muscles. And again, it's not been proven when I say this, but to me, it seems to show the signs, the ability for shifting back and forth in whatever way is needed, back and forth on this carotid area. So if the lower end of this was to contract, it would pull, take that whole carotid sheath with it. If the upper end was to contract, you would take that carotid sheath again with it. So it means it can slightly change the position, slightly pull in, left, right, a little bit backwards and forwards on that as needed as we're going through neck rotation. It's an interesting muscle, and so it probably has an interesting function. So the take-home point from this is that though it's not proven yet, there could be relationships from the muscular system to the visceral, the organic system, and we should hope to find those in the future and hope to clear those relationships up. The other part is we need to be really careful when we're working on the neck. This area right here has a ton of nerves. I've mentioned the vagus, but of course we've got a lot of sympathetic nerves that go through, and they are pretty deep. We've got three main guys coming through here, but there's a whole sympathetic chain that goes through there. There's some important cranial nerves like the 9th cranial nerve that goes through there, and even that phrenic, which I painfully neglected to mention but had to do it on purpose. Even that phrenic is coming through and descending and controlling the action of the diaphragm and sensation of the lungs, pericardium, and bare area of the liver. So when you're working on the neck, when you're doing anything to the neck, you really do have to be careful because you might be stimulating more than you think. This has been Elge from Subluxations Anatomy. I hope that made sense.